I want to thank Elaine and the organizers for inviting me to speak today. It's funny, I come to these meetings to catch up with people who I work at the same institution with sometimes, so it's been fun talking to Len in the back. So I'm going to be talking about liquid biopsies, and primarily the clinical application of liquid biopsies. There's a lot of fundamental research behind this, but what I thought we could focus on, what can we actually use these liquid biopsies for, and can we move from just using this for research and discovery to really applying it to answer some unmet clinical questions that could never have been answered before? And you got a little bit of a taste of this in Elena's talk. These are my disclosures. Leave it up there for a second. And I'll begin with the model of cancer evolution. And this is not gastroesophageal cancer, but colon cancer. And this is normal colonic epithelium that goes into an adenoma, which is a pre-malignant state, then an invasive state, then a metastatic state. And we know what governs this really is time. This is the accumulation of changes over time. Actually, that can be measured histopathologically with changes that are very clear and characteristic, but also with the accumulation of key mutations in genes that offer a selective advantage to these cells for growth and invasion and for survival. I think the important thing to realize is that this doesn't happen in a week, this doesn't happen in a month, this doesn't happen in 1 year. Typically this happens over decades. And that is both a disadvantage and an advantage in that it gives us, it's something that evolves over a long time, so it's hard to treat once it gets down to the metastatic setting, but it gives you the advantage of intervening early with a diagnostic that might be able to catch these cancers early. So when we talk about mutations and the accumulation of mutations, mutations offer a very potent biomarker in that we define them as not being in normal cells, but being present in precancer cells and cancer cells. So from a theoretical standpoint, it gives us almost perfect specificity. And that's incredibly valuable when you start thinking of a biomarker, because the false positives for any biomarker are what drive the failure rate and what drive a lot of issues as you develop those biomarkers. And we'll talk about that a bit later. So what do we know about cancer mutations currently? Well, we pretty much know the mutational spectra in every cancer type. It's a rare cancer type that hasn't been sequenced to date in both adult and children. And this is not only by panel sequencing, like IMPACT, but whole exome sequencing and even whole genome sequencing. And if you look at the current catalog of somatic mutations present in tumors and not in the normal counterpart for that patient, we're in the 1 or 2 to 3 million mutation range. And I can tell you that the majority of those mutations, we have no idea what to do with. They're biologically interesting, but we don't have a clinical step forward once you see those mutations on the report. In addition, there's probably only about a dozen genes that are mutated that have a FDA-approved therapy assigned to them. So the vast majority of these mutations do not have a clinical value. And so that's something that I've been trying to focus on. What can we use the somatic cancer genome data for? And the dream was as a predictive biomarker, and you heard some of this from Elena and Nikki earlier, is that you'd find a genomic alteration, you'd marry that with a therapy, and the tumor would melt away. It's not happening. It actually happens incredibly rarely, and if it does work sometimes, the tumor becomes resistant. So that has been not so simple of a strategy. We're getting there. There are some alterations where we do have targeted therapies that do melt away tumors, but they're the exception rather than the norm. So I think we have a lot of work to do there. The other area is as a prognostic marker, and I'll give an example in colon cancer again, or lung cancer, or brain cancer would be another one. So IDH mutations in brain cancers portend for a better prognosis, BRAF V600E mutations in colon cancer portend for a very poor prognosis. Aneuploidy, so a disorganization of the genome, structural changes in the genome. Non-diploid genes portend for a worse prognosis than diploid tumors. So some of this genomic data is giving us a prognostic marker. So that was the initial hope. We'd get all the sequencing data, we'd learn everything we need to do, and we'd create designer drugs that would get us to exactly where we needed to. But when I started my work, that seemed too hard for me, and the prognostic markers really didn't change, other than a conversation with the patient, where we could go therapeutically and how could we achieve cure. So initially, began working on liquid biopsies. I'll say briefly, immune antigens is something that's come up lately. These mutations, certain classes of these mutations can appear foreign to the immune system and can actually be harnessed in combination with immunotherapy to unleash a very potent anti-tumor response. One example is MSI high tumors. They have an incredibly high number of mutations, and that makes the tumor look foreign, and you can unlock a very potent anti-tumor response with checkpoint inhibition, as Yelena showed. But what I'm going to focus on is, can we use mutations as dynamic biomarkers? And can we move beyond just an interesting phenomena as a dynamic biomarker and into something that we can clinically use going forward? So how do we normally find somatic mutations? Typically tumor tissue, formalin fixed or frozen tissue. But what I'm going to be talking about is using these bodily fluids, either cell-free DNA or circulating tumor cells, as a source of these mutations. And they can come from either just drawing blood or other bodily fluids, which I'll talk about. So when we talk about liquid biopsies, you can go all the way and say, okay, a liquid biopsy, a blood draw, even a finger stick for glucose is a liquid biopsy. You can say that measuring your hemoglobin is a liquid biopsy. But currently, in 2018, what encapsulates liquid biopsy are these novel molecular biomarkers that are either secreted or released during cell death via apoptosis or necrosis into the peritumoral fluid and then enter the circulation or that bodily fluid. And what I'm going to be talking about today is circulating tumor DNA. So fragments of DNA that all of us have in our bloodstream, that when you draw the blood and you take the supernatant, not the cells, and extract DNA from that, you can measure actually a number of different things. And so if I took DNA of blood from anyone in this room, separated out the plasma, extracted the DNA, and then ran that DNA in a gel, the majority would be like here on the right, or my right, is this ladder here. And that ladder is consistent with the same ladder we see during apoptosis. We have cells going through apoptosis all the time in our bodies, whether they be skin cells or from the GI tract or blood cells. And that's what you see. That's normal plasma DNA. But if you're undergoing necrosis, for instance, if you had a stroke or an ischemic event, a heart attack, you'd start seeing big sheets of DNA into the circulation because it's unorganized death, just release of DNA into the circulation. So those are the two kind of flavors of DNA that we get in the circulation. And when we look at that pool of cell-free DNA, as I said, the majority comes from the bone marrow, but you do see a lot from the GI tract, the skin. And if you have a pregnant individual, a fraction of that DNA into that pool comes from the fetus. And you can actually genotype a fetus just by drawing the blood of the patient. Likewise, if you have a transplanted tissue, like a kidney or liver, in that pool of DNA, you also see DNA from that transplanted tissue, and you can see a number of things there. And if you have cancer, a fraction of that DNA comes from the tumor and enters that pool of cell-free DNA. So you have this pool of cell-free DNA. How do you differentiate what's from normal tissue and what's from tumor? Well, let's go back to the mutations. You look for wild type or normal DNA and compare it to mutant DNA in that pool of DNA that you get from the patient. And so that way you can differentiate both and you can measure. You can count mutations, you can identify mutations, you look for changes in mutations. And so I'm going to go through this quickly. There are two major ways of assessing the mutant DNA in anyone's blood. One is a technique called digital PCR. It's very cheap, very fast, but you have to know what you're looking for ahead of time. And the second way is using next generation sequencing. Memorial has a panel now that it's bringing up live soon. And there you can look at large regions of the genome, and you can look for new mutations or a variety of different mutations. It's expensive. It requires a lot of bioinformatic analysis, and the turnaround time at best is 1 to 2 days, typically 1 to 2 weeks. But these are the two major methodologies to detect cell-free DNA, or mutations in the plasma of individuals. So what can we do with this? Well, we can do a variety of different things. We can simply draw individuals' bloods and find mutations that you can maybe use therapeutically. You can monitor tumors. As the levels go up or go down, it will track with the amount of tumor in the body, almost like a CEA or PSA. You can track resistance. And I'm going to be showing examples of each of these in the latter half of my talk. So this is an example of a patient responding to therapy, a patient with melanoma getting immunotherapy, and this was a palpable tumor that initially got bigger, then decreased, and then completely disappeared. When we measured the ctDNA, the patient went up, but then became undetectable. Before the tumor even was palpably undetectable, we believe that there was two things going on. One is a inflammatory response around that tumor, because this patient was treated with checkpoint inhibition. And the second is the scar takes more time to resorb than what was actually became undetectable as a lack of tumor tissue. So it gave us an idea that we could track tumors using this methodology. One of the more interesting approaches is, can we track resistance? And the answer is yes. Using targeted therapy as an example, this is back a number of years ago when we knew that patients with EGFR blockading colon cancer had to be wild type to have a chance to respond. And typically you'd have a tumor, it would respond, and then become resistant again. And we used EGFR blockading colon cancer as a model. We knew that primary resistance was because of mutations in KRAS. The response rate was 17%. But we didn't know what secondary resistance was dictated by. So what we did was we took these wild-type KRAS patients, treated them with an anti-EGFR antibody, and lo and behold, these patients, when we measured KRAS in the blood, went from wild-type to mutant over time, and that corresponded with the patient responding and then becoming resistant by their CEA biomarker and radiographically. But what surprised us here is that not that we saw one KRAS mutation, but that we saw multiple KRAS mutations emerge over time. And then we looked at other genes in the pathway: NRAS, KRAS, BRAF, EGFR, PI3 kinase, PTEN mutations. And what we found was that each row is an individual patient treated with an EGFR inhibitor. They're wild type in all these genes, but now they're becoming resistant, or they're acquiring mutations in many of these genes over time. So they're evolving into a new genotype. And what we could show is, by looking at the whole pathway, was that the mutations typically occurred in the RAS-RAF pathway, inclusive of the EGFR ectodomain, but really devoid of PI3 kinase, PTEN, and AKT, and the rest of that pathway. So it allowed us to show us a pathway that was involved in EGFR resistance. But it also showed us something more sinister about single-agent targeted therapy, which is the following. This patient was KRAS wild type, and actually wild type in NRAS, not MET amplified, not EGFR mutant. And we just pushed this patient into being KRAS mutant, NRAS mutant, MET amplified, and EGFR mutant. We know how to treat this patient. I don't have any idea how to treat the patient with all those mutations. So it presented a problem that is true of virtually all targeted therapy, that doesn't cure you. If it doesn't cure you, you will probably eventually recur, and that recurrence will be a complex recurrence genetically with multiple new targets or multiple mutations and resistance pathways that need to be targeted. So it's a problem we have to overcome. The easy solution to say is to let's just do multiple agents. That's easy to say, that's very hard to do, because each of these agents not only have a different therapeutic index, but they also have a different toxicity, and when you combine them, those toxicities can be combined. So a big challenge for our drug developers, but it's something, it's better to know what's going on than to not know what's going on. Minimal residual disease is something that Yelena spoke about in her talk, and that's basically the concept of the following, that the majority of our patients here at Memorial and elsewhere with cancer are initially treated with a definitive therapy with the objective of cure. And if we take colon cancer, esophageal cancer, breast cancer, most of those patients are early stage. They have a chance for cure. It's actually the 1/3 to 1/4 of patients that are metastatic. How do we bring drug development and precision medicine to these earlier patients? And this came up as an idea of how to do that. And a way to potentially answer a question that's really not answerable. So definitive therapy, let's take surgery for example. After that definitive therapy, despite all our knowledge of TNM staging, despite all our knowledge that we see histopathologically, we can't tell the patient if they're cured or not. We can't. And in fact, we have to wait 5, maybe 10 years in many cases to tell them if they're cured. And we give patients with certain risk stratification where there's data, adjuvant therapy. But that adjuvant therapy is treating both patients who are cured and not cured. So we're doing this careful balance of treating with attenuated chemotherapy that won't hurt the cured patients by surgery alone. And we're probably not treating intensely enough for the patients who may be cured. Because by definition, they're metastatic. At that point, the tumors just haven't grown up. So is there a methodology that we can use to differentiate who's cured and who's not, either immediately after surgery or soon thereafter, so we can solve this question and begin drug development in a slightly different way? So there have been other systemic approaches to look at minimal residual disease, imaging, protein biomarkers, circulating tumor cells, and they all have their advantages and disadvantages. But primarily it's specificity, and in many cases it's lack of sensitivity. We were interested in seeing if cell-free DNA or circulating mutant DNA could actually solve this issue. And so this was a study that we began really back in 2005, but we completed in 2008. And this is a patient going a potentially curative surgery for metastatic colorectal cancer. This patient in the resected tumor had an APC mutation. We had blood from before the surgery, 1 day after the surgery, 42 days after surgery, and then 244 days after surgery. And this fragment here, this quadrant here, shows the mutant APC fragments before surgery. 1 day after surgery, you see the mutant fragments here in this quadrant, and you can see they increase over time. The CT scan was negative at day 42, but became positive at day 244. But if you look back, we were sensitive enough on 1 day after surgery to know that there was remnant circulating tumor DNA in that patient's body. Now, the first question one should ask is, well, what's the half-life? Could they just be hanging around? And the half-life of these fragments is somewhere between 1 and 2 hours. And typically below the limit of our detection is after 5 half-lives, so 10 hours, that should be gone. This was at 24 hours. So those fragments were still sticking around, and even when the CT scan was negative, they were still there. So that gave us hope, so we started looking at a larger cohort of patients. But first we compared it to a protein biomarker with a very long half-life, 2 weeks, which was CEA. And these were patients all undergoing potentially curative resection. And we measured CEA 6 to 8 weeks after surgery. And we showed here that those with detectable or above the normal limit, the majority or all recurred in this case, and many recurred with undetectable CEA. Statistically significant, but not clinically satisfying at all. But when we looked at circulating tumor DNA in this situation, those that were negative or undetectable levels all remained disease-free, whereas those with detectable circulating tumor DNA after surgery, so mutations that match their tumor that were also found in the plasma, 6 to 8 weeks after surgery, the majority recurred. There was a small pilot study more recently in collaboration with Peter Gibbs and Gene T in Australia. We did 250 stage 2 colon cancers. After resection, their tumors were sequenced, And then we looked 4 to 10 weeks after that resection to see if they had any of the mutations in their tumor also present in the plasma. And we found something very similar. The patients that were positive all tended to recur, whereas those that were negative did not. Now, this has been performed in pancreatic cancer, neuroblastoma, lymphoma, lung cancer. And the good news is the positive predictive value of a positive circulating tumor DNA test of a mutation that matches your tumor is in the 90% range. The bad news, or the confusing news, is if you're negative, the negative predictive value is currently about 50%. So if you're negative, it doesn't assure you that you're cured, but if you're positive, the likelihood that you're going to recur is in the 90%. So there is still more work to be done there. So we're not going to be able to withhold therapy, but we will probably be able to opt into better therapy for those individuals. So that's where we are with minimal residual disease. I think there's a lot of potential there, but there needs to be a lot more work. I'm going to pivot to an area where I think where we can have the biggest impact, but it's also the biggest challenge, and that's early detection. Can we use this technology to look for mutations theoretically in healthy individuals and find cancer early just by sequencing their plasma DNA and finding cancer-causing mutations there? And this is a study that we published in 2014. We looked at 14 different tumor types across a variety of stages, sequenced their tumor. Before the surgery, we had blood drawn on all these patients, and we found that we could detect a little bit over 40% of stage 1 cancers, where the cure rate's incredibly high. This is the dynamic range of that biomarker. So it's not perfect, but the sensitivity increased as the stage of the patient increased, and this is across a variety of different tumor types. So it gave us a glimpse that maybe this could be used for early detection. But what really drove it home for me was not in cancer patients, but in healthy women who were pregnant, who were undergoing cell-free DNA testing to see if there were genomic abnormalities in the fetuses or the babies they were carrying. And this is an example of a case of one such patient who they actually called our group, and we talked them through these cases, where they were finding changes in the genome of the plasma that weren't consistent with something going on in the baby. And then the baby was delivered, baby's healthy, no abnormalities, but the genetic changes persisted in the mom. And this patient was found to have stage 2A Hodgkin disease. Now, they're doing millions of these tests now. And this is 400,000 tests that were done. And there were 38 confirmed aneuploidy. What does confirmed mean? They persisted after the baby was delivered. Baby was healthy. The changes in the genomes of those mothers weren't from abnormalities in the fetus, abnormalities in the mother themselves. And a whole host of both benign and malignant diseases were found in the mothers based on this finding. So they weren't looking for cancer. They were trying to screen the babies to make sure they were genetically okay. They happened incidentally to find cancer. So to me, this actually, in addition to studies that we did and others have done, drove home the possibility of using cell-free DNA for early detection. So I'm talking about blood here. Could you do even better by getting closer to the tumor? And so one strategy we used was to look at saliva. And would that actually enrich for DNA and cells from head and neck cancers? And the answer is yes. And if you add on a causative agent, HPV or EBV, the sensitivity and specificity go up even much higher. Another approach was, could you take a simple pap smear? And could you take patients who have abnormalities in the ovary or uterus, and would the cells or DNA survive and lodge in the cervix? Could you take DNA from that pap smear, sequence it, and then diagnose these patients with cancer? And what we found was, surprisingly, that we could detect all 100% of endometrial cancers when we did this, and about 40% of ovarian cancers, even at very early stages. So these cells in DNA would survive that transit and lodge in the cervix and allowed us just a simple pap smear to pick these up. So when you take all these approaches currently that are being used for early detection, both in the research setting and in some cases in the clinical setting, you can look at different bodily fluids or excrements like stool, urine, blood, pap smears, and saliva. Focus on the tumors you're trying to diagnose. Think about the DNA source. Is it tumor cells? Is it cell-free DNA? Is it a mixture? You start to get a sense that just by assaying different bodily fluids, you might have a comprehensive way of diagnosing cancer. I think it's very early days, but there's a ton of challenges. Challenge number one, not all mutations are cancer. And there are entities, things like clonal hematopoiesis, that develop in individuals as we age. There are mutations in the bone marrow that look from any perspective like cancer, but they're not. They're just cells that have acquired a growth advantage that happen to have these mutations that look like cancer. We found an endometriosis, mutations in PI3 kinase and KRAS. And there have been mutations in a variety of other things and things like aneurysms. So we're finding mutations that look just like cancer, but aren't cancer yet, or will never become cancer, or have a low chance of becoming cancer, that will confuse this approach. So we need better technology, more data to help untangle that web. The other issue is localization. This is a patient that came to me a number of years ago, had a KRAS mutation in the blood. They were doing this in China, and I didn't completely understand where he was getting it done, but he was getting it done. He was terrified. He had CT scans, PET scans, colonoscopies, PSAs were all normal. What is this? Where is it coming from? We have no idea. We just have a blood draw. And the scans didn't show anything. We reperformed the test in Baltimore at the time, and he was negative, which brings up a whole different issue, which is of quality of testing. But if it were real, where do you focus your attention? You don't know. He just becomes a high-risk patient. So that's a challenge going forward. And another challenge is heterogeneity. Not all tumor types shed the same cell-free DNA. And I'll point out here, gastroesophageal cancer sheds a lot. And a lot enters the circulation, so we're able to assay it quite nicely. And you'll see from Yelena's studies, I think that will be one of the reasons why cell-free DNA will be very promising, both in the advanced setting and in the early stage for detecting gastroesophageal cancer and using it as a tool to help direct drug development. And then finally, there's a biological limitation. There's just not a lot of molecules in the blood. So either you have to draw a lot of blood or the tumor has to be advanced, and hopefully new technologies will come out to help address this. So challenges, first, there's the biology. Not all clonal events are cancer, i.e. not all mutations are cancer. Second is a heterogeneity. Third is localization. And the fourth is there's just not a lot of molecules in the blood, so you need very good technologies. There's also another thing, and I think this is symptomatic of a lot of things that we do in medicine, that we need to focus on unmet needs. And I think that's where we can make the biggest steps, and that's why I kind of focus on minimal residual disease and early detection. Those would be huge steps forward if we could solve those problems. They're incredibly challenging, but I'd like to see us put more attention as a community into those areas. In terms of the future of ctDNA, I think we're going to see an increase in the amount of comprehensive panels. Right now, we're limited more by biology than technology. There's not a lot of cell-free DNA that gets secreted into the blood. And we need more biological-based research because we need a biological-based discovery to drive things forward. So for instance, we have these low levels. How can we increase them? Is there a mechanism of either increasing release or decreasing excretion or metabolism of these fragments so they're being more abundantly in the blood? So that's something that many people are working on. In terms of genotyping, it's here. There are multiple commercial entities doing circulating tumor DNA sequencing. There are multiple entities even entering the early detection space. But we need the same intelligent development of clinical trials that we have in advanced disease to evolve into early stage disease and even for preclinical healthy screening. Currently, I think that there's going to be a lot of studies out there that are develop more confusion than real pathways forward. So we need high impact applications that drive improvements in survival. And that's going to be challenging. That's always challenging to develop. And we need these as prospective studies in partnership with the FDA, because in those type of conversations will really drive things forward. So I'm going to stop there, acknowledge a lot of people who I initially did this work with at Hopkins, although this is starting to move forward here at Memorial, and some of the sponsors that are ongoing here. So thank you very much, and happy to take any questions.
Dr. Diaz, is there any potential looking at like CD133 or other stem cell antigens before they, as a standard where those cells are probably going to express it, not involved, but also maybe when there's low minimum and there's not high expression from normal tissue, that you may be able to see the stem cell population rising before the other markers come up?
Yeah, so I think that would be interesting, especially because if you could isolate those cells and grow them out, the mutations would probably be heritable in that cell. And so that might give you an advantage. I think that's a good idea. Some individuals have been looking at that in bone marrow, and that might be a repository for those cells.